So I'm going to keep this quite light, and I thought I'd keep it quite short. And it's aimed principally at trainees. The days of running around the UK and Europe and going over to Ireland to train people for TAVIs has gone. It's best part of a year since I last did anything like that. And what's happening now is that a lot of people have the skills locally and they can disseminate it to other local centres. I think as far afield as I've been recently, St George's. And it means that we will then be moving into training people who are coming through and bringing them up through the ranks. So in how should these trainees approach TAVI? How should they get involved?
I thought I would go through... Sorry, Chris, that your AV's not working. Just... Oh.
Right. So I thought I'd just go through, for the trainees, how you should go through developing your skills. And so I'll tell you all you need to know. And that's it. I would say to all surgical trainees, don't do it. I think it is the wrong place to concentrate when you've got 250 cases under your belt. And I think that the issue is that where my generation had done 1,000 cases when they became a consultant, the current people coming through have done about 250 cases. And so they have no experience in the more complex cases, and what they've done so far has generally been quite straightforward and not a high volume. And I think that the current generation should actually not be doing TAVI. I think that's what I've advised our latest trainee, Michael, who's just come through. But at the same time, what is going to happen is we're going to continue to see cardiac surgical cases that get older, that get sicker, and that have many more comorbidities. And so your surgical skills are going to have to be all the better. The idea, when I started, there were single vein grafts, the LAD. There'll be people in 20 years' time saying, we once used to do an isolated AVR. Things will get more and more complicated. And the other thing is that I think that TAVI will very soon become the province of cardiology. I think as soon as ProStar and similar devices get their complication rates down from the current sort of 15% down to 2 or 3%, cardiology will try and cut us adrift. I know that in Germany at the minute, patients are having TAVI procedures in centres that have no cardiac surgical input. And to me, that's wrong. And to me, the main thing is to stay close to what's going on, stay part of the decision-making process. Now, I think that the surgeons that are coming through at the same time need to have a far greater range of skills than the current surgeons or that I have. Because the surgery will be more complex, they will be less frequent, and I think hybrid techniques, not only with aortic valve, but with mitral valve and with aortic aneurysm surgery, will start to flourish. I spoke to Lars Svensson about 6 months ago, and he said that at the Cleveland Clinic, the vascular surgeons are getting the cardiac surgeons to come and open the cases because they do so few open cases that they don't have the skills anymore and they require the cardiac surgeons to get involved. So I do think that the future surgeon will need radiological skills, and I think that is where they should be concentrating at present, not learning how to blow up a TAVI and how to position it, but actually learning much more of the basic skills that are required in interventional radiology, interventional cardiology. But as I said a few minutes ago, to me the key is to remain part of the decision-making process, because as long as you do that, you will increase your experience, you will stay close to the coalface, and you will stop terrible things happening. I don't know how many cardiologists there are in this room. I can see one ignoring it, which is good. But in the days of angioplasty, cardiology went wild, and there was no rollout of the technology in the way that there was with, or has been, with TAVI. And I think that as long as we remain part of this decision-making process, that we'll actually continue to influence things. I just want to show you a couple of studies. and show you where actually blowing up the TAVI balloon is a minor part in all of this. This is a Mr. PP. He's an NHS patient. Those are his initials. And he was a 63-year-old man, severe aortic stenosis, with a small valve area, and yet his gradient was only 28 millimeters across the valve. He'd got moderate MR, he'd got severe TR, and he'd got an ejection fraction of 17%. Now, he had a dobutamine stress echo to confirm that this was severe aortic stenosis, which it was, but his contractile reserve was really pretty poor. And in the past, he'd had 2 years coming in and out of hospital with multiple heart failure admissions. He'd gone into AF, and he was also not the easiest of candidates. He was 130 kilos, he had impaired respiratory function, he was on home CPAP, diabetic, hypertensive, and an ex-smoker. And you can see on the screen there that he does have tight aortic stenosis, and he does have a pretty wrecked LV. The only thing that moves on that side, I think, is the mitral valve. You can see as well that he's got mild AR, severe TR, poor left ventricular function. In fact, you can see the TR there, severe MR. So he's got a lot of things going on in here. There's his dobutamine stress echo as well. PA pressure is up at 62. His logistic Euro score comes in at 17% when you add in all those various factors. And so there's a TAVI MDT meeting at which a cardiac surgeon wasn't present. And the cardiology decision in that process was for a TAVI. We then had another meeting because we don't make decisions in isolation. But the cardiac surgical decision in this setting was that we should proceed to cardiac surgery, and Vinny Bapat and myself were both agreed. And we felt that leaving severe TR in the presence of raised PA pressures and moderate to severe MR was inappropriate. And so this gentleman underwent, thankfully successfully, a triple valve procedure. So here we are. This is the sort of case that will be coming up for more junior surgeons. Here you get thrown a case of do you do a TAVI, which I think is inappropriate, or do you do what is actually a very complex and high-risk procedure? Now, he had quite a turbulent time in hospital, coughed his sternum to bits, had multiple reconstructions, got a flap that got infected and had a second flap. But he came through it after about 4 to 6 weeks in hospital. The second one is a guy that's under review at the minute, and I think we may well show him later in the year. But this gentleman came up just 2 or 3 weeks ago. Now, in 1975, he had a Hodgkin's lymphoma and had mantle radiotherapy. He also had radiotherapy all around his groins. And he now comes in with angina, which I think is important, because often we ignore coronary disease if there's no angina, but in the presence of angina, I don't think you can. And clinically, he had aortic stenosis, and you can see the aortic stenosis that he's got. You can see that he's got quite a gradient across that valve. But he's young. And here again, you can see that his mitral valve is not working very well. It's thickened. He's got thickened posterior leaflet. He's not particularly got much in the way of MR, but what he has to me is got a pan-carditis from his radiotherapy. His left ventricular function is not good, and he's probably got an element of myocardial fibrosis. And he does have coronary artery disease. So he's got proximal disease in both the LAD and in his right, and more distally. And you can just make out here some calcium. In fact, when we did a CT scan, his whole ascending aorta is covered in calcium right down in towards the root. So we've got a young man with a very complex problem who has aortic stenosis, impaired left ventricular function, but actually the consequences of his radiotherapy are really quite dramatic. And it's a case of what should be done here. And cardiology are discussing whether he could have a TAVI and a PCI, whether he could have an AVR and cabbage. But what they have no concept of, I don't think, is the aortic root. And they were putting him up for, if we could only just get a clamp across this, couldn't you do an AVR? But this, to me, can only be dealt with by taking out the root, the ascending and the arch, if you're going to take that on. What they haven't thought through, and again, which I think is a good cardiac surgical input, is the MR. Now, I think you can do a mitral valve replacement. Almost certainly, to me, this will be so fibrotic when we get there, but you can do it without a cross clamp on cardiopulmonary bypass via the right chest. And so for me, there are surgical options. I would even go as far as to say that transplantation ultimately may be required. The few that I've seen that have had this have all ended with in tears at the end. And so to me, I think bringing a surgical approach to a case like this adds an awful lot. But if you throw that case to the surgeons, now in one case, this one we're going to do a TAVI, but in the last one I was suggesting that we did a surgical operation. But I think it's vital that the surgeons are involved. Now, what I worry about is that TAVI will go on freely without us, and I think that will happen in the very near future, personally. But I think the MDT is the forum where we can plan sensibly patient care. I think cardiac surgical input into all aortic valve cases, particularly the complex ones, are vital. And I think for the trainees that they will find increasingly complex surgical cases. I think those may be in lesser volumes. We've been hearing today about stenting the ascending aorta, and people will be attacking conventional surgery from all sides. I think what junior consultants, new consultants should be training on is improving their surgical skills. But I think they also need to develop generic skills which will facilitate many hybrid and minimally invasive techniques, because I think that's where their future will lie. And I think they should engage in that and learn as much as they can from it. But I don't think they should necessarily be thinking about blowing up balloons and deploying TAVIs. Thank you very much.
Any questions from any trainees? If you argue the counterpoint, though, that if you look at the Leipzig experience, they've very much taken TAVI under the surgical wing. Wouldn't that be a reasonable way to move forward for surgeons, and to keep it within sort of at least a relatively balanced approach in terms of not just the MDT forum, but also the actual operative forum? Because I think some of the wire skills, no disrespect to interventional cardiologists, but they're not the complex ones that you need for blowing up complex angioplasties, and should be within the remit of most cardiac surgical trainees, I'd say.
I think the success of the programme is that everyone's got together at the beginning. It's got a balanced input from all sorts of people. And so now that that's grown, we can't take it over. What has happened is we used to have, for transfemoral, 2 cardiologists, and the cardiac surgeon was just making the hole and closing it. Now we've lost one of those interventional cardiologists, and the cardiac surgeon is becoming the second operator. And I think that has improved our skills quite dramatically. And I can see Vinny Bapat is really pushing to become first operator transfemorally, and he wants to go down that route. But to me, if you see cardiology read some of these root shots and look at the calcium and look at the views and say, no, that just needs a little bit of RAO and it'll be fine. The skills that they have, we should not underestimate. And just because we can hold a wire in a ventricle and not have it come out doesn't make us good TAVI operators. So I think for us to take over that role, we actually need to learn a huge number of other skills that perhaps we don't realise.
I take that point, but that's what I'm saying. Having worked in a unit where I am effectively the second or the first operator, irrespective of what we do, you pick up those skills, and then they're not. What I'm saying is, the surgical side in your unit, who's going to replace me in my unit and other places. We've got to bring people along, otherwise the balance will completely go towards cardiology because we're not engaging our newly appointed consultants or senior trainees to take on that role.
Well, I think they should engage in the MDT because I think that's one of the most important things. They get exposed to all the different cases and they have an input into which go medically, which get watched, which get various interventions. And that process of assessing a patient can mature. In terms of all the registrars that come into theatre, I think, learn a huge amount from observing TAVI. They may not push the plunger, but that's why, as part of the early programme, everybody involved in the programme went into every case. And so even though we weren't doing it, we could see whether it was too low or too high. We could learn how to get out of trouble. We saw problems. And so being there teaches you a huge amount. The actual final delivery, I believe, is a relatively easily taught and small part of what is a much more complex, bigger problem.
There's a question over there. And one over right here.
Hi, I'm a core surgical trainee working in Liverpool. Just when you were talking about the cardiologist taking over the TAVIs, where I am, I'm involved in looking after the patients post-operatively. So I wonder if cardiology were taking over in some more centres, whether it would be the cardiologist looking after the post-operative complications, because I think you have a slightly different viewpoint coming from a surgical background than you do coming from a medical background. And maybe that's as important as the pre-operative decision-making.
I think it is. We send most of our cardiology ones would go to coronary care, and they personally would look after them, whereas the surgical ones, so they get extubated on the table, whereas the surgical ones go to the surgical facility because they've had a mini stenotomy or whatever. Cardiologically, I think that we are closer to our patients than the interventionalists are. I think their volume of work is much higher, and so I think that they skim the surface more of each patient, and the patient experience tends to be much quicker in and out, whereas our patients are in for a week. They're often quite sick, and so we see much more of them. But I wouldn't hold your breath on cardiologists seeing death and coming back to us and saying, we don't like it. We've been through that with angioplasty. They have been through the bad side of angioplasty and come back. And if you look at the results of angioplasty now, they're absolutely fantastic. And that, I think, is what will happen with this, that it will go out, it will become widespread, it will be abused in certain times, and then it will come full circle back to where it is the most appropriate place to be.
Well, I share some of your concerns, and on the other hand, I still have a little bit of different view. I mean, I share your concern that actually one wonders at what point of their career the trainees you see these days learn to deal with the complex patients of the future. And you wonder in particular of that when you see how difficult it is for young consultants to start their practice and deal with the complex type of conventional surgical work they have to deal with, and without different kind of support from the whole unit than I believe which was presented in the past, I think most of them would not be able to start actually a practice. On the other hand, looking back into my own my own training, I think if someone would ask me what was the most important step for myself to be able to start a TAVI program, to deliver what we have done at King's, to have a proper cooperation with the cardiologist, to be respected on their side as I'm among surgeons, I believe it was the 2 years of training I had in cardiology at an early stage after I had 3 years of surgery beforehand. So based on that experience, I would personally say one does need to have some cardiology training earlier. And I agree with you, it's maybe not necessarily the case that you need to know how to inflate a balloon, because that's straightforward. But I think if you want to cooperate in a way that you are respect yourself in a team, if you want to build a team, it's important that you learn to understand how the other side is thinking. And that's the reason why I think the heart team, you're right, is important, because in these heart team meetings you learn how the non-invasive part of the medical team is dealing with this kind of heart valve disease, and the other way versa. So that's the reason why I think we need to involve juniors in a different way in the heart team. I think it's not important that they play the surgical role necessarily, but I think they should, in a very early stage of their training, develop the idea to become a heart specialist instead of a necessarily surgeon or cardiologist. And if we would manage to create this kind of individuals, then I think not only for TAVI but also for other kind of heart valve treatment, non-coronary type of treatment, we would have the opportunity to build up training programs where actually we have people who have an organ focus instead of a specialty focus approach. And I think that would be helpful to deliver what has to be delivered, and to look at some of the approaches, let's say the transapical or the transfemoral approach, from a more objective point of view without a personal agenda on our shoulders all the time.
Well, we've got a hybrid theatre being built in our complex at the minute, and I hope that our cardiac surgeons will be in with the vascular surgeons and will be picking up those sorts of skills, because they need more than simple surgical skills that we learned. And I've done 3 thoracos this year, and they've been the most complicated ones that there are, because they're stenting everything else. And that's the other thing about the future. It's going to be a complex, open surgery.
There's a question, Mum, to you.
I was just going to add a comment. I think a lot of this in terms of experience refers to local factors, and how things evolve vary quite significantly depending on the skills, the interest, and how teams work together. And I think there's a surgical bias at the start of the programme, as I think there is in Liverpool, with a high transapical approach, then things have evolved accordingly. Your point's interesting. In the States, they are talking about this sort of a disease process approach to management and hence training, and incorporating training for vascular surgeons, cardiac surgeons, cardiologists, recognising that it's now an overlapping field, and trying to integrate that early on. So I think there's something to be said that I don't know how easily it can be delivered, particularly in this country and the way training works, but certainly there's something quite intuitive about that.
There's one question at the back, the last question there.
Oh, sorry. Hi, I'm Betsy, the trainee representative. Can I just say that it's all great hearing, that everyone's concerned about trainees, but actually I've been trying for the last 2.5 years to try and get some experience crossing over between vascular surgery and aortic surgery from a cardiac surgical background, and it's nearly impossible in the UK to do that. There's one place in the UK where they've adopted a modular approach to training from an early stage, but I don't think that translates through to the end of the training programme, and that's in Wales, where people spend a period of time with cardiologists, a period of time with echo specialists, interventional cardiologists, as well as vascular and cardiac surgeons. But I think this seriously needs to be addressed, because everything that you're saying, we come to the end of our training having done 400 or 500 cases, and that's great if you've done that much. But, as you say, people are doing 200, 300 cases and then thrown in the deep end, and being a part of a MDT setting in that environment with that experience is just impossible, and it's daunting. So it really does need to get addressed. That's all.